Hello everyone, welcome to my video channel. Today I will be covering regarding part 3 of traction in orthopedics. In this video, the topics that I will cover are regarding Stamen Pin. What is it? How many types of Stamen Pin there is? The sizes of Stamen Pin, the length of Stamen Pin, what are the indications of Stamen Pin insertion, what are the contraindications, the side effects of the insertion of the Stamen Pin itself. At the same time, I will cover regarding Denham Pin, Kirschner wire or frequently called K-wire, and finally regarding the sites of pin insertion. The disclaimer is the same in all my videos. Thank you. Now let's begin. Again, what is skeletal traction? It is a traction that is applied through a direct fixation to the bone. The most commonly used pins in skeletal traction are 1. Stamen Pin, number 2. Denham Pin, number 3. Kirschner wire, or we lovingly call it K-wire. Now, let's start with number 1, Stamen Pin. Stamen Pin is a thin metal rod, rigid stainless steel pins of varying length in diameter. It is commonly used in orthopedic procedures for holding a large bone fracture together. These pins function similarly to K-wire, but are larger in diameter. Bolus stirrup is attached to the Stamen Pin, which allows the direction of the traction to be varied without turning the pin in the bone. Stamen pins are available in various types, length, and diameter. The types are single trocar, double trocar, single trocar threaded, trocar and threaded, center threaded. For the diameters, it starts from 1 mm, then 2 mm, 2.5 mm with an increment of 0.5 mm till 7 mm and lastly 8 mm. The length starts from 100 mm to 200 mm. I am showing you the image of varying types, lengths, and diameter of the Stamen Pin. I highlighted the trocar and the threaded part in the illustration. Okay, now let's proceed. What are the indications of Stamen Pins? Among the indications are as a temporary or permanent skeletal traction that is usually used in DCO, damage control orthopedic setting. In bone trauma that requires an internal fixation for healing. Fixation of soft tissue to bone where the pins are able to do so safely. Example, it is used in the thigh amputation. In bone lengthening and or shortening procedures. Example, in bone loss case in severe trauma case, where the involved bone loss is more than 5 cm. Another indication are in osteotomies and other realignment procedures. What are the contraindications of Stamen Pin insertion? Please consider patient condition as a general. Among the contraindications are acute or chronic infection, either local or systemic infection, local or systemic and acute on chronic inflammation. Another contraindication is the affected region is compromised. Example, in muscular disease, nervous system disease, or in vascular disease. Other contraindications are defective bone structures, which will impede adequate anchoring of the implant. Lastly, any associated disease which would impair the function and success of the implant. Factors that will impair the success of operation using Steinmann pins include 1. Allergies to the implanted materials. 2. Localized bone tumors. Number 3. Osteoporosis or osteomalacia. Number 4. Systemic disease and metabolic disturbance. Number 5. Patients who are unable to understand and comply with the doctor's instruction. 6. Poor general health. What are the possible side effects from using the Steinmann pin? A. Loosening of the implant, which may result from cyclic loading of the fixation site and/or tissue reaction of the implant. B. Early pin site infection and late infection that will lead to the formation of osteomyelitis. That means infection of the bone. C. Further bone fracture resulting from unusual stress or weakened bone substance in the first place. D. Temporary. That means it's neuropraxia or chronic neurodamage, neurogenesis resulting from pressure or hematoma formation. Another possible side effects are E. Formation of wound hematoma that would not resolve, causing irritation. This irritation will lead to delayed wound healing due to hyperinflammatory process. F. Formation of heterotrophic ossificans. G. Pain and discomfort due to presence of the implant. H. Mechanical failure of the implant, including bending, loosening, or breakage. I. Migration of implant resulting in injury. Next pin I am going to cover is number 2, Denham Pin. Denham Pin is similar to Steinmann Pin except for a short threaded length situated in the center and held in the introducer. This pin functions similarly to K-wire, except that it is larger in diameter. Denham Pin engages the bony cortex and reduces the pin sliding. Denham Pin is used in A. Cancellous bone and B. Osteoporotic bone. Like Steinmann Pin, Denham Pins are also available in various types, length, and diameter. The types of Denham Pin are single trocar with center threaded pin, double trocar with center threaded pin. The diameters of the Denham pins started from 2 mm, then and 0.5 mm increment till 7 mm or millimeter. The lengths include 100 mm to 300 mm or millimeter. Again, as a reminder, as Denham Pin is almost similar to Steinmann Pin, the indication, contraindication, the side effect, etc. is the same with the Steinmann Pin. Last of the pins are number 3, Kirschner wire, or we call it short K-wire. K-wire is a thin, smooth wire with a diameter of 1.0 mm to 2.0 mm. The advantage of K-wire are that it is easy to insert, it minimizes the chance of soft tissue damage or infection. The disadvantage of the K-wire are it rotates within an improper bow and cut through the osteoporotic bone. These complications are reduced by using the proper traction bow. We call it a ta-da! I will show you later. Even though the K-wire is small in diameter and flexible, it can withstand a large traction force when the proper traction bow is used. This special bow is named Kirschner bow. Easy. Provides the wire with rigidity by applying a longitudinal tension force. If properly placed and not improperly stressed, the wire does not break and cause less bone damage than the larger Steinmann pin. Based on the illustration, for proximal tibial pin traction, for shaft of femur fracture, for a larger Steinmann pin usage, the bowler bow is in use, where the knee is flexed in 30 degrees. For the C, as illustrated, the tensioning capabilities of Kirschner bow allow the usage of smaller K-wire. Okay, you guys understood the illustration? Now next, we are nearing the finishing line. Lastly, I am covering example of sites of skeletal traction. I am going to cover regarding the greater trochanter site. We can use either Stamen pins or Denham pin. The point of insertion is 2.5 cm below the greater tuberosity. Nope, sorry, not GT. Greater trochanter. Midway between anterior and posterior surface of the femur. The direction of insertion is from lateral to medial side. Among the indication is central fracture dislocation of the hip. As illustrated, the Stamen pin is inserted based on the blue line. So the X-ray shows a very bad fracture dislocation, isn't it? Okay, another site of skeletal pin insertion is B, distal femur, by using a Stamen or Denham pin. First, flex the knee to 30 degrees, palpating the patella for neutral rotation. The point of insertion is 2 to 3 fingers above the superior pole of the patella or around 3 cm from the lateral joint line. There is an illustration provided. The direction of the pin insertion is from medial to lateral. I will follow the AO recommendation. Some will suggest from lateral to medial. Indication for distal femur pin include acetabular fracture and femoral shaft fracture. C. For distal tibial pin traction, the point of insertion is 5 cm above the level of the ankle joint, midway between the anterior and posterior borders of the tibia. The direction of the pin insertion is from medial to lateral. In this, we can avoid the saphenous vein. The pin is placed through the fibula to avoid a peroneal nerve. The indication include in the certain type of tibia plateau fracture. I will provide an illustration or picture about the distal pin insertion. And the final site is D, calcaneal traction. The point of insertion, a line drawn from the tip of calcaneum to medial malleolus. Entry point is 2/3 from the line drawn from the medial malleolus to the tip of calcaneum, or 2 cm above and 2 cm distal to the calcaneal tuberosity. The direction of the pin insertion is from medial to lateral. This is to avoid a posterior tibial neurovascular bundle. Indication include in-tibial shaft fracture, pylon fracture, and subtalar fracture. Before I conclude this video, this chart shows a summary of traction that is used in orthopedic setting. The traction can be used in fracture involving proximal or mid-shaft femur fracture. It can be divided into skin traction or Thomas Pin, or skeletal traction, example 1990, or Perkins traction. For fracture involving the distal femur or proximal or mid-shaft tibia, it can be divided into skin. We call it a buck traction. Or skeletal traction can use a distal tibia or calcaneal traction. For forearm or distal radius traction, in skate traction, we use a finger trap traction. For skeletal traction, we can use a metacarpal pin traction. For mid-shaft of distal humerus fracture, for skin traction, example Dunlop traction. For skeletal traction, we can use a olecranon pin traction. As for cervical facet dislocation or hangman fracture, as previously covered in my part 2 video of Gardner-Well-Tong, for skid traction, halter traction could be used. Okay, I need to elaborate more in a later video or in another video. For skeletal traction, Gardner-Well-Tong can be used as a temporary or permanent method of traction and later can be changed to hollow vest. Or once the fracture is united, we can use collar as an additional stabilization. Yay! We have finished the topic of traction in orthopedic. I could almost. I hope you have learned something from this video. Till we meet again, see you and bye.